Hi everybody and welcome to Let's Talk Science. Let's Talk Science is a new podcast that we created here at the IBE, LMU's Institute for Medical Information Processing, Biometry and Epidemiology. Our guest today is Dr. Frederick Southwick of the University of Florida. We're interviewing Dr. Southwick because we'll talk about interleukin-6 inhibitors and Baricitinib, two new treatments for COVID-19. Dr. Southwick is a professor at the University of Florida. He trained in internal medicine and infectious diseases at the Mass General. In addition to his advocacy in patient safety, he's also a prolific educator with his own YouTube channel. He's also the author of a McGraw-Hill Lang series edition on infectious diseases, a clinical short course, which is also available on MD Access. And as we'll get into the podcast, he's the instructor of a Coursera course on COVID-19. All studies that we mentioned during the conversation will be linked in the show notes. If you have any comment on the podcast, please head to our YouTube channel and leave us a comment. We'll appreciate it. Let's get started. Fred, it's so nice to talk to you again.
Good to talk to you.
Thank you for joining today's show. So we're going to talk about two new therapies for COVID-19. But you run a Coursera course on COVID-19. What's new with that?
Yes, I started that course actually in late February of 2020. And I really decided to teach the course because there was so much disinformation. Even physicians didn't really understand what was going on. One of the prime examples being hydroxychloroquine, which I was fighting against from day one. Because the evidence was not there. And so I really, what I started off with was understanding the pathogenesis, the epidemiology, the clinical presentation, and treatment were the initial focus. And then I realized that clinicians needed a little bit more detail, and I didn't want to overwhelm those that were the lay public that were watching the course. So I created a fourth module, which is it's optional, but that's for clinicians. And you have helped on that course. That's how we met. So really a physician's perspective on this. And there we're using more technical terms that others might not understand. What I try to do in the rest of the course is I try to avoid doctor speak and try to speak in clear language that anyone would understand. Every now and then I probably slip into a medical term, but I tried very hard not to do that as much as possible.
Mm-hmm. That's great. And I understand it has over 4,000 course participants?
16,000.
16,000. That's amazing. Yeah. We'll put a link in the description of the video and in the show notes. But today we'll talk about two new therapies for COVID-19. So there aren't a lot of therapies. So far, there's Dexamethasone, a steroid. There is Remdesivir, which has probably a direct antiviral effect. And then low molecular weight heparins or DVT prophylaxis. And then other drugs as needed. But there's two new therapies, right?
Yes. Yeah. The experience is quite good with Remdesivir. The WHO says that Remdesivir doesn't work. But I think the reason for that is that often it was delayed and the therapy was delayed. I think if you get Remdesivir early, it's of definite benefit. And I think overall the studies do demonstrate a benefit to that drug. And you do see the viral loads go down. And in my experience, you see the lymphocyte count increase within 2 or 3 days of starting Remdesivir. So the combination of then I like to have the Remdesivir at the same time or before the Dexamethasone, because Dexamethasone theoretically could impair antiviral, your ability to fight a virus. But what it does is it suppresses the overwhelming inflammatory reaction to that virus. And one of the things that is relevant to the two drugs we're going to discuss is that this virus really stimulates the innate immune response, because when it binds to the ACE2 receptor, it stimulates TLR3 and TLR4, And then when it's producing the foreign RNA in the cytoplasm of cells, it stimulates TLR7 and 8. So it has four pattern recognition receptors that are all telling NF-kappa B to this pathway to activate, which releases a large number of cytokines, including IL-6, TNF, interferon. All of these are turned on. And the problem that we end up with is excess inflammation that causes predominantly severe lung damage, but can damage other organs.
Mm. And so it's only telling that only one of those four drugs is has a direct antiviral effect, or the other ones are basically immunosuppressants, correct?
That's correct, yes.
So why don't you tell us about these two new groups of therapies, I guess we should call them?
Yeah, the IL-6 inhibitors are all monoclonal antibodies directed against the receptor of IL-6. So IL-6 can't bind and stimulate. And so we know that the IL-6 levels can be very high. Normal would be under 5. I've seen them up to, I think, 120. Although there are other ARDS syndromes which actually have higher IL-6 levels than this. So we don't use the term cytokine storm. It's just an elevation of IL-6, and probably appropriate, but unfortunately, this does cause excess inflammation that causes lung damage. So the big question is, when should these IL-6 inhibitors be used, and should they be used alone or in combination with dexamethasone or another corticosteroid? And I think the evidence is very good that you should combine dexamethasone with one of the IL-6 inhibitors. Whether one IL-6 inhibitor is better than another, I doubt it. I suspect they're all would be equivalent if they were studied in the same way. One of the big problems I've seen with all these studies is there are many that are very small series, and those tended not to show as clear efficacy. The larger series tended to demonstrate the efficacy. The differences, the impacts are relatively small. We're talking 8 to 10% improvement, I think, overall is what my assessment would be. So these are not home runs. And unfortunately, nothing, when it comes to treatment of COVID-19, nothing has proved to be a home run. They all chip away a little bit. They reduce the mortality a little bit. They shorten the hospitalization a little bit. And they reduce the likelihood of being on a ventilator a little bit. And so, but adding them all up, I think certainly when you're talking the large numbers of cases, they will make a difference, and they do make a difference.
Yeah, that reminds me a little bit of the early days of HIV, where you combine drugs through cocktails. Maybe their resistance was more of a problem, but it sounds like we don't have a silver bullet, and you have to add up the effects of all these different drugs.
And then as far as the Baricitinib, which is the JAK-STAT inhibitor, that drug, really, JAK-STAT pathway does multiple things. It's used in some cancer chemotherapies is where it was started, and then some autoimmune diseases. But it's like it's a little bit like a bomb to the entire signal transduction pathway. We really don't know which pathway is being impacted. We do know that IL-6 levels are down. We do know that interferon levels are down, and other cytokines are reduced. So it's very much like glucocorticoid in that it suppresses large numbers of inflammatory mediators, and it's not particularly specific. So, and there's really only one big study that just came out in the New England Journal, which just shows some efficacy. It reduces the likelihood of ending up on a ventilator. It does seem to show, again, modest benefit. And so, but it should be used instead of glucocorticoids. It should not be used with them. So the study is with Remdesivir, and Baricitinib, and there was a distinct benefit. So I think that, but the big question, which we've discussed, is when most people can take dexamethasone. When would you not use dexamethasone and use Baricitinib? And I really don't have an answer to that. When they trial for Remdesivir and this drug Baricitinib was being performed, dexamethasone, right in the middle of that trial, the rescue trial showed the tremendous benefit of dexamethasone. So now the study is a little bit, the results, I think it's a little difficult to know what to do with them, since most of the time we're going to use dexamethasone. And as also we discussed, if I have a choice between a new drug, which does not have a lot of clinical experience, versus a drug that has been around for 20 years, I'm going to take, and they seem to be equivalent, I'm going to use the drug that's been around for 20 years. Mm-hmm. So for me, most of the time, I'm going to use Remdesivir and dexamethasone rather than use Remdesivir and Baricitinib.
Mm-hmm. Yeah, these four drugs are all compounds that have been used in other diseases. I think Remdesivir was only trialed in Ebola and had to be approved, but all the other ones are approved for other purposes and then were repurposed for COVID-19. Right. I guess Janus is this Roman Greek god of the beginning of the end. So maybe we can talk about the indication for Baricitinib. So you mentioned that it should be used in patients who are already on Remdesivir, and so in addition to Remdesivir, but who are not on dexamethasone or another steroid, correct?
That's correct. Yes. Yes. Mm-hmm. Yeah, I actually I'm working with some physicians in India, and what I learned in India, the steroids are used very frequently all over the country. In fact, there's people called quacks who actually give, when you come to see them, they almost always give you a steroid. And guess what? You feel better temporarily. Mm-hmm. So there's a long history in India of using a steroid. And then they added Baricitinib. And what they're seeing is cases of mucormycosis, large numbers of these cases. And mucor is a very deadly fungus, a black mold fungus that really does not lend itself well to treatment. So it has the potential to really be dangerous if you combine a corticosteroid and Baricitinib.
Mm-hmm. So people who are at risk for severe infection, maybe of the risk of perforation, shouldn't be on Baricitinib. And similarly, people on IL-6 inhibitors, their lymphocyte and their platelet count can be too low. So everybody who is at risk or who has another severe infection, you should be careful with all of these, correct?
Yeah, absolutely. Absolutely. My experience with COVID-19 is, as we talked about, you're revving up the entire immune system. And in the first 12, 14 days, I personally have not seen bacterial superinfections in that setting. And so I think it's very low likelihood early in the disease that you're going to have bacterial or fungal infections. Now, the Chinese literature seems to emphasize the possibility of aspergillosis. Mm-hmm. Now those studies I've reviewed them, are highly questionable in that aspergillus is in our environment and you can culture that as a colonizer almost anywhere. And so if they have a case of COVID that has pneumonia due to COVID and they do a sputum culture and grow aspergillus, they say it's due to aspergillus. I think in most cases it's not. And I have been watching the literature, maybe I have looked at all the autopsies reports, and I have not found I cannot find a documented case of invasive aspergillosis. The only way you can say that it really is aspergillosis is a biopsy that shows the fungus invading vessels. And I have not found one case like that as yet. I'm sure there are some, but I don't know, Ben, have you found any in the literature?
No, I haven't heard of any. Um, so not something for serious infections. The indication for baricitinib is very narrow because there's almost nobody who cannot be on steroids. Maybe if you have cerebral malaria or something. What about the IL-6 inhibitors? And maybe we should also call them by name. So Tocilizumab is the one that's mostly widely studied, and there's also Seralimumab, who was in the Remdesivir trial, if only in a minority of patients. And then there's a third IL-6 inhibitor, and also direct IL-6 receptor inhibitor. But what is the indication at the moment for those IL-6 inhibitors in patients with severe COVID?
Well, you want to be sure that they have significant inflammation. And so what the studies have treated with these drugs, Tocilizumab is the one that's we have the most experience with. And it's a CRP of greater than 75. So, and then they should have significant hypoxia, and ideally the best outcomes, the greatest benefit in those that are on high flow oxygen before they get on a ventilator. And there is evidence that may reduce that does reduce the likelihood of them requiring a ventilator support. So there does seem to be in some of the studies, a mortality benefit as well. So, and the number of days requiring, oxygen support goes down. So I think there is reasonable evidence that it will be of significant benefit in those severely ill patients. A mildly ill or moderately ill, you would not use these drugs.
Mm-hmm. So to summarize, patients who are on high flow or worse, and those who might be headed to the ICU maybe in 24 to 48 hours?
Yes, yeah. If they're at that point, that is when you should use these drugs.
And that's of course if they're already on dexamethasone. Always dexamethasone first.
Yes, that's the other important thing. Some of the original studies with Tocilizumab just looked without dexamethasone, and it was of questionable benefit in that setting. So I think the studies indicate that you want a combination of dexamethasone and Tocilizumab to really show these benefits.
Yeah, it's funny you mentioned these early studies. They were interpreted as negative studies, but I noticed they have this very wide confidence intervals. Do you think they were just underpowered maybe?
I think a lot of them were underpowered. They were 300, 200 patients, and that just is not enough to show benefit. One of the problems that I've seen, and I know you have as well, is that the course of this disease is extremely variable. One day a patient is really well, and the next day they crash, and there's no rhyme or reason to it. And one of the problems we got into with observational studies is we would think that our therapy had improved, but that was just the natural course of their illness. So observational studies have been particularly problematic when it comes to COVID-19. And I would not believe any observational study for this disease. You need a randomized controlled clinical trial to judge efficacy of any reagent. And I think that's where we got into huge problems with hydroxychloroquine.
Mm-hmm. Yeah. And even these bigger studies, recovery and Remap-Cap, are only moderately sized, and I think you really only see the mortality benefit that you spoke of, maybe 15-20% roughly, if you combine those in a meta-analysis. Maybe that's also because the patient population is very heterogeneous, and not everybody is on steroids, for example. The majority, though.
Yeah, I think that's a problem when you've got big studies like this. You've got to get the numbers. The more you collect, the more heterogeneous the population is, and the more difficult it is to show efficacy. And one of the ways that I was just actually listened to a statistician point out that really what you'd like to do is you'd like to create segments of patients that are all the same. and actually do individual comparisons between each of those groups, which might really get around this problem of heterogeneity. Now, the problem, you need a huge series to do that, and Tocilizumab has not been available to large numbers of patients, and that's one of our problems. So the larger the study, the better, and then segment the patients into comparable clinical categories would be very, very helpful, and I think would show distinct efficacy in certain groups and not in others. And that would really help. When you think about it, we want to individualize the care for our patients. For example, maybe people with CRPs of 200 or greater are the better benefit rather than greater than 75. But we can't, the numbers are too small right now to segment them off in that way. And you'll just get, you can't prove statistically that it's a benefit. So it needs a large series, and then you need to actually classify the patients into comparable clinical severities and other characteristics.
Yeah, and those two studies that showed a benefit, I guess they were open label studies. On the other hand, they had really the patients that we see with severe COVID in the hospital. So I guess biostatisticians would mention that they're not double-blind studies. But on the other hand, maybe the studies are a little bit closer to the real world. What do you think?
Yeah, I agree. What I really like is I looked at the IDSA, which is using grade to actually assess the evidence. And for Tocilizumab, actually they have they feel there's moderate likelihood that's of a benefit. And there aren't serious biases, but there are design problems in the studies. So it's not a slam dunk. It's not high evidence. It's moderate evidence based on very rigorous assessment of the quality of the evidence and the research design. So I really think that using grade is very, very helpful because of the complexity of the studies. And it's very difficult for you or me as a reader to actually make these judgments. So I recommend going to the IDSA for each new drug and looking at their grade analysis, because I found that, for instance, hydroxychloroquine early on, they had low to no evidence, and these studies were extremely biased, and they were observational studies. So right off the bat, they were pointing out that these studies, although in peer-reviewed journals, were seriously flawed.
We're going to link the IDSA guidelines in the description below or in the show notes. And yeah, the certainty of evidence was moderate, but of course these are critically important drugs. We still have, what, 10-15% mortality for inpatients, higher of course in the ICU. So every bit of decrease in mortality helps.
Absolutely, yeah. This disease, depending on the age and underlying diseases, is a really frightening disease. I got, as you know, I didn't go in the hospital for 1 year. I had managed patients virtually and did consults virtually because I was very afraid of this disease and the mortality. When you look, and from 50 on up, it's really a linear relationship between age and likelihood of dying. And when you get up to about 80, it's somewhere in the 25 to 30% mortality range when you get above that to that age. So, and then you add in underlying diseases, anywhere from 5 to 10% increase in mortality with different underlying diseases. So, boy, it's very dangerous. And anything we can do to benefit is very important.
Yeah, and I know in addition to virtual consults, you've also done a ton of education. And again, we'll link to the Coursera course and to your YouTube channel. Thank God we have vaccines now. And thank you so much for all your experience and for your opinions, Fred. We appreciate it.
Thank you. Good to talk to you.
All right, thank you so much for watching. If you want to hear more of those conversations, please follow us on Spotify or subscribe on YouTube. And if you have any comments on the podcast, for example, who you want us to interview, then please comment below. Thank you and see you in the next one.